Welcome back, everyone, to a massive milestone. This is Explainer 100 of our 150-part IPDRG masterclass right here on Decode Healthcare with Harshal. I am so pumped to be your lead instructor today as we hit this century mark. In Part 99, we laid the groundwork with the medical DRG side of MDC-12. But today we're shifting gears. We are tackling the highly complex, high-stakes world of the advanced surgical DRG deep dive for MDC-12, the male reproductive system. Now, real quick, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Seriously, your support is exactly what lets us keep bringing you this comprehensive curriculum completely for free. Okay, let's get into it. All right, here's our agenda for today's explainer. 1. MDC and surgical partitioning. 2. The ICD-10 PCS code structure. 3. Root operations, precision matters. 4. The CC/MCC financial impact. And 5. Summary and next steps. Let's dive right in. Starting with Section 1, MDC and surgical partitioning. So how exactly does a patient's case get routed into a surgical DRG in the first place? Well, it all comes down to partitioning logic. The absolute golden rule here is that if a procedure meets the CMS definition of a major operating room procedure, boom, it automatically overrides the principal medical diagnosis and triggers a surgical DRG assignment. And for MDC-12, we are looking at a massive spectrum of surgeries. We're talking everything from major oncological pelvic resections for cancer, all the way to emergent scrotal or testicular trauma management, and even advanced prosthetic interventions. Moving on to Section 2, the ICD-10 PCS code structure. Now that we know why a case goes surgical, let's break down the anatomy of the procedure codes themselves. You guys know this, but every ICD-10 PCS code is a highly specific 7-character alphanumeric string. Every single digit matters. Character 1 is the section. Character 3 is your root operation. So what's the actual objective of the surgery? Character 4 gives us the specific body part. Character 5 defines the approach, like is it open or percutaneous endoscopic. The main takeaway here: if you miss just one of these characters, or maybe misinterpret a physician's operative report, the entire code and potentially your entire DRG is completely compromised. And this perfectly illustrates our focus for today. Check out those body system values. Notice how the second character for any male reproductive system procedure is the letter V. So whether the surgeon is operating on the prostate, the scrotum, or the testes, as long as we're in the medical and surgical section, that second character, V, locks us right into our specific anatomical neighborhood. Which brings us to Section 3, root operations, precision matters. Okay, quick pop quiz. What is the exact difference between excision and resection? Seriously, take a second and ask yourself this, because this one distinction is literally the backbone of our high-volume surgical MS-DRG families, specifically DRGs 707 through 718. Precision here is totally non-negotiable. It's how you defend medical necessity, and it's how you survive compliance audits when classifying major pelvic, penis, and testicular procedures. Here's the definitive breakdown. Excision, that's character B, means you are cutting out a portion of the body part without replacement. Resection, which is character T, means cutting out all of a body part. Let's look at MS-DRGs 709 and 710 for penis procedures. Getting the surgeon's operative report right is just paramount here. For example, coding a partial penectomy for penile carcinoma, that maps to an excision. But a total penectomy with a groin lymph node dissection, that maps directly to a resection. Now, what gets really interesting is applying this logic to prostate and testicular procedures. Take a radical prostatectomy for adenocarcinoma, like an open or robotic-assisted laparoscopic approach, which lands in DRGs 707 and 708. That is coded as a resection. But a transurethral resection of the prostate, or TURP, despite the name, that's actually an excision because they're only removing a portion. It's the exact same story for DRGs 711 through 714. A radical inguinal orchiectomy for germ cell tumors is a resection, while a simple scrotal orchiectomy for something like a severe infection is coded completely differently. We also have to keep an eye out for other root operations, like insertion for penile prostheses treating severe erectile dysfunction, or repair for things like an acute penile fracture or testicular torsion requiring a bilateral orchiexy. Let's pivot to Section 4, the CC/MCC financial impact. All right, let's zoom back out from those granular procedural codes and look at the patient's entire clinical picture. The MS-DRG system relies on a triplet structure. Capturing complications and comorbidities, your CCs and MCCs, is what dictates your base payment multiplier. No secondary complications, you're in the lowest payment tier. Add a CC, you bump up to the middle tier. But if the documentation supports an MCC, the case gets elevated to the highest possible relative weight. Which makes sense, right? It reflects the massive increase in hospital resources actually required to care for that patient. So, the crucial takeaway here is that specifically documenting and coding conditions following a major reproductive surgery changes the entire game. If a patient develops a postoperative hemorrhage, urinary leakage, or a deep vein thrombosis after a major pelvic surgery, well, those are incredibly powerful CC and MCC drivers. Severe urosepsis is another huge one. But listen, vague documentation simply won't cut it. You need the highly specific diagnoses sequenced correctly with those present on admission indicators to ensure the hospital is accurately and fairly reimbursed for that complex postoperative care. And finally, Section 5, Summary and Next Steps. Consider this your master blueprint. Step 1. The principal diagnosis establishes the MDC. Step 2. Major OR procedures pull that case right into the surgical partition. Step 3. We rigorously interrogate the operative report to assign that exact 7-character code, making sure we catch those vital distinctions across DRGs 707 through 718, like excision versus resection. And Step 4. We concurrently review for any urological CCs or MCCs to lock in our final DRG triplet tier. That is how you build a bulletproof case. Before we wrap up, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. I'll leave you with this thought. If a single word in an operative report, like excision versus resection, can literally swing a hospital's reimbursement by thousands of dollars, is your clinical documentation truly capturing the complexity of the care you provide? Something to chew on. Take all the surgical hierarchy logic we covered today and get ready, because in Part 101, we're applying this exact same rigorous approach to Body System U, the female reproductive system. Thank you so much for joining me for Explainer 100, and I will see you in the next one.